So the introduction of guideline-focused medicine, what Harrison and Woods described as scientific bureaucratic medicine, was a policy change introduced in the NHS quite recently, only in the 1990s. It marked a significant shift in healthcare practice, with two key elements that changed the way we practice medicine. So firstly, the scientific bureaucratic medicine model defined the best knowledge for clinical practice is that derived from external research evidence. Secondly, scientific bureaucratic medicine recognised that guidelines were the best way to deliver that external research knowledge into frontline clinical practice. It was argued those changes were needed to improve the quality of healthcare, quality and safety, including being able to protect vulnerable patients from the harm of too much healthcare. And some improvements followed. For example, as we've discussed, the measurable impact on screening and management for hypertension. But, as authors like Cox remind us, any theory of knowledge production has a power dimension. And the introduction of scientific bureaucratic medicine had a power dimension element because it shifted perceptions of trustworthy knowledge for practice from an internally generated understanding in context created between patient and professional working together to an external arbiter of truth, if you like, from guidelines. At the heart of scientific bureaucratic medicine is the evidence hierarchy described by evidence-based medicine, which privileges that external knowledge generated from experimental scientific research. Evidence-based medicine also recognises professional opinion as the lowest form of knowledge, but it also fails to advise on how to distinguish between opinion and appropriately created knowledge in context or mind lines. The result is that clinicians fear using mind lines over guidelines. They avoid doing so, and hence we end up with the unintended consequences that we've already been discussing. Patients are left feeling unheard and overburdened by guideline care. Clinicians experience the burnout of trying to manage complex problems in context without the tailored knowledge in context that they need. So the introduction of scientific bureaucratic medicine was a choice. It was a choice made in the 1990s, a decision that was made about how we manage risk, the risk to patients from healthcare, as well as the risk to public budgets from healthcare systems. And if we want to change direction on how we manage risk and deal with knowledge in practice, we need to first understand what it is that stops clinicians from stepping outside of guideline care, from tailoring care to the needs of an individual patient in front of them, even if they can perceive that that might be the right approach to take for this individual. That's a question we've been asking in research studies repeatedly over 15 years or so. We've asked clinicians why they follow guidelines even when they think it might not be the right thing for their patient. And the results have been pretty consistent over that time as well. GPs in particular describe 4 barriers to delivering tailored advanced generalist practice. 4 barriers that we've described as the 4 Ps. So the first P is a perceived lack of permission. clinicians perceive that they don't have permission to work beyond guidelines. Even if NICE say that they're guidelines, not tramlines, for a clinician, it doesn't feel like that. The second P is a lack of prioritisation. Sometimes it's just quicker to follow the guideline, to simply make or reject a diagnosis and then move on to the next patient, even if the problem's not fully resolved. Quicker to do that than take the time to understand a whole person assessment of the problem and consider the broader options available. The third P is a reported lack of professional skills and support to develop and maintain those skills. Clinicians describe being taught evidence-based medicine, but not safe and effective practice for beyond evidence-based medicine. Some lack the skills, but also the confidence to know when and how it is safe and appropriate to use beyond guideline care. And the fourth P is a perceived lack of supportive performance management. So working beyond guidelines means our care may not meet the expected or measured standard of care, for example, in QoF. Our patient might like the decision we make. We together may feel it's the right decision, but the performance standards say we've done something wrong. So clinicians can end up needing to choose between doing the right thing for their patient and satisfying their patient, and doing the right thing for the external performance management systems that they work in. So the 4 barriers that we consistently see: lack of permission to do it, lack of prioritisation within routine everyday care, lack of professional skills or confidence to use those skills, and lack of supportive performance management. Do you recognise any of those barriers in your daily practice?